Good day, everyone. It's a great pleasure for me to be here with you today. My name is Dr. Anna Georgina Cierre Fokine. I'm a pediatrician with subspecialty training in pediatric cardiology, which I completed at the National Medical Center 20 Noviembre. Today, I will be sharing with you our study titled Retrograde Percutaneous Closure of Patent Ductus Arteriosus Experience at the 20 Noviembre National Medical Center, which reflects our department experience. This topic is particularly relevant because PDA remains one of the most frequent congenital heart defects, and understanding alternative interventional approaches, especially in patients with complex anatomy, is crucial to improving outcomes. We have no conflict of interest to declare regarding this presentation. Here are the main topics which we will go through the presentation: introduction, methodology, results, conclusions, and references. As we know, the patent ductus arteriosus is normal fetal vascular connection between the pulmonary artery and the descending aorta. The persistence of this vessel beyond 3 months defines the patent ductus arteriosus, or PDA, which accounts approximately from 5 to 10% of all congenital heart defects. Incidence is 1 in 2,000 live births. The presentation is most frequent at altitudes more than 2,500 meters and in preterm infants, particularly those who were born before 32 weeks of gestation or weighing less than 1,200 grams. The echocardiography remains the first-line diagnostic tool for anatomy and hemodynamic assessment. The percutaneous closure is the treatment of choice, and traditionally, it is most commonly performed via anterograde or venous approach. The clinical significance of this study lies in the fact that very few studies clearly defined indications for the retrograde approach, and the early diagnosis and timely intervention are crucial to prevent serious complications such as endarteritis, heart failure, pulmonary hypertension, Eisenmenger syndrome, all of which significantly impact long-term morbidity and mortality. Our main goal was to describe the clinical indications, outcomes, and complications of retrograde percutaneous PDA closure in pediatric patients treated between 2015 and 2024 at the National Medical Center 20 Noviembre. Also, this study seeks to unify criteria for retrograde PDA closure. This was a retrospective cross-sectional study that was conducted at the National Medical Center 20 Noviembre, including pediatric patients who underwent retrograde percutaneous PDA closure between 2015 and 2024. The statistic analysis was performed using SPSS. Our quantitative variables were analyzed using measures of central tendency and dispersion, and our qualitative variables as frequencies and percentages. The Kolmogorov-Smirnov test was applied to assess data normality. Based on literature and sample size calculation, at 95% confidence, a minimum of 16 patients was required. Of our 16 patients, the mean age was 5.06 plus minus 4.4 years. Of these, 10 were female, that represent the 62.5%, and 6 were male, 37.5%. The mean weight was 22.2 plus minus 18 kilograms. More than 60% were undernourished, and 62.5% presented hemodynamic repercussion. Something very important is that 14 of our patients had a small ductus. The mean diameter was 1.7 plus minus 0.7 millimeters. Several occlusion devices were used depending on the ductal size and anatomy. In our population, the most frequently used occlusion devices were the amplatzer ductus occluder type 2 and the coil. Each of one of these represented the 37.6%. We also studied and analyzed the morphology of the ductus arteriosus, focusing on the diameter of the pulmonary end to better understand which were the anatomical characteristics that led us to select the retrograde approach. In our series, 3 patients, 18.7%, had a pulmonary end measuring 1 millimeter or less. 7 patients, 43.7%, had a pulmonary diameter greater than 1 and up to 2 millimeters, while 4 patients, or 25% of these, had a pulmonary end between 2 and 3 millimeters, and only 2 patients had a larger ductus, measuring 4.2 millimeters and 6.3 millimeters, respectively. As you can see, most of our cases involve small pulmonary ends under 3 millimeters. The majority had a pulmonary ending less than 2 millimeters, which clearly supports the indication for using the retrograde percutaneous approach in this group of patients. As shown in the previous slide, the majority of our patients with a ductus arteriosus measuring less than 3 millimeters. So this was the point of cut that we defined as a small PDA. This subgroup included 14 patients, corresponding to 87.5% of our population. The main reasons for which we chose the retrograde approach were a small pulmonary end size by angiography in 9 patients, that it was 56.2%, failed anterograde cannulation in 5 patients, this was 31.2%, and vascular anomalies such as interruption inferior vena cava and cortation of the aorta. Each of one was presented in 1 patient, that represented the 6.3%. As previously described in the population characteristic, the most frequently employed devices in our court were 802 and coils. In the first 2 images, we observe examples of patent ductus arteriosus closing using 802 device, whereas the subsequent 2 images illustrate the closure with coil devices. The retrograde approach in our court was successful in all cases. Minor complications were presented in 3 patients, the 18.7%, mainly transient arterial vasospasm, and there were no complications in 12 patients. It was the majority, 75%. 93.8% of our population had improvements such as improved functional class, weight and height gain, preserved biventricular function, absence of upper respiratory tract infections. 1 patient, unfortunately, passed away 1 year later due to aplastic anemia. It was unrelated to the cardiac procedure. 86.6% of our patients were discharged 1 year after follow-up. Only nowadays, 2 patients are continuing under follow-up. Our results confirm that the retrograde percutaneous closure of PDA is a safe and effective procedure in all ages, such as described by Campagna and Dalby. In our court, the mean age was 5.06 plus minus 4.4 years. 62.5% of our population were female, and this is similar to the described by Sarmento, Satananda, Vie, and Grenstein. The mean PDA size in our patients were 1.7 plus minus 0.7 millimeters. 87.5 were described as small PDA, defined by the diameter less than 3 millimeters. And this was the main indication for the retrograde closure. This is consistent with the reports of Zawi, Zhu, and Greenstein. Regarding the devices used, coils were employed in 37.6% of our patients, mainly in those PDAs that were measured 1 to 2.8 millimeters, consistent with previous reported data by Campania, Zawis, and Hani. The Emplatter ductal type 2 also was used in 37.6% of our patients. We achieved a 100% of success, mainly used in patients with a weight beyond 6 kilograms, where we had a one successful case in a patient that weighed 4.980 kilograms, and it's in accordance with findings by Mahmoud and Dane. The vehicular device, we used it in one preterm infant that weighed 2.265 kilograms, and it is consistent with the FDA approval in 2019 for using infants that weighed 700 grams, and this was also reported by covered in 2023. 75% of our patients had no adverse event. The transient vasospasm occurred in 3 patients, as we have said, and none of these had a sequel. And it is consistent with the reported by Greenstein, Damien, and Shad that the most of the population has no serious complications. The success rates were excellent and were comparable to previous studies, such as made by Mahmoud, that he used 802 in 95 patients, and he reported a 98.2% of success. Also, it is said that it is feasible in small infants, as described by Damien and Sanjani, such as we did it in our study. 93.8% of our patients had clinical improvement, 86.6 were discharged after 1 year, and this is comparable to the international experience. The strength of our study lies in its exclusive focus on retrograde PDA closure with clearly defined indications for clinical decision-making. We had a limitation that the PDA length data was incomplete. We have not consistently reported via echocardiography or angiography. So we highlight that this is the need for standardized measurement in future studies. In our experience, the retrograde percutaneous PDA closure is a safe and reliable procedure for patients of all ages with minimal transient complications. We propose as definitive indications such as pulmonary ending less than 3 millimeters, Krichenko type E tubular ducts, absence or malformations of the inferior vena cava, and failed anterograde PDA cannulation. And like probable indications, the presence of aortic partition, such as to avoid multiple vascular punctions and reduce the procedural time, residual postoperative shunts with distorted ductal anatomy, patients with a body weight beyond 2 kilograms, and abdominal aorta diameter beyond 10 millimeters. We suggest that the most effective devices for retrograde PDA closure were 801, 802, coil, and piccolo. It's important to highlight that the 802 was specifically designed for retrograde closure of PDA. And together with the coil device, these were the most frequently used in our patient population. So for us, the most effective devices are 802 and coil. I would like to make a final remark just to summarize that the retrograde PDA closure is safe and reliable procedure. It allows for excellent clinical outcomes with minimal complications and contributes to expanding therapeutic options in pediatric interventional cardiology. So we should continue doing retrograde percutaneous PDA closure at all ages. I would like to express my sincere gratitude to the National Medical Center, 20 de Noviembre, ISTE, for their valuable support in providing access to clinical data and research facilities, which made this study possible. Additionally, I want to thank my co-authors for their invaluable contributions and dedication throughout this study. Thank you very much for your attention, and I will be happy to answer any question if you have one. Excellent day.